All right, welcome back to the deep dive. Today we're tackling something really specific, something right at the heart of high-stakes revision, especially if you're staring down the MSRA exam. We're doing a deep dive built just for you, looking at some revision material on a condition that often pops up, mycosis fungoides. Our mission is simple. Slice through the complexity, pull out the absolute must-know info you'll need. Think of it as streamlining your study, focusing on the high-yield stuff.
Exactly. We're diving into the core material here. The aim is a clear, structured overview and connecting the key dots for mycosis fungoides. For revision, understanding what it is, how it presents, and crucially, how it's managed efficiently. Well, that's absolutely critical. We'll help highlight what's most important from the info you've got.
Okay, perfect. Let's unpack this then, starting right at the beginning. What exactly is mycosis fungoides?
Okay, so fundamentally, mycosis fungoides is a rare type of cutaneous T-cell lymphoma. CTCL for short.
Right, CTCL. So it's a kind of immune cell cancer, but specifically starting in the skin.
Precisely. Cutaneous means skin. And yeah, it falls into the non-Hodgkin lymphoma umbrella cancer of the lymphatic system. But unlike many lymphomas starting in lymph nodes, this one kicks off in the skin. It's characterized by these abnormal T-cells, specific white blood cells becoming cancerous and basically infiltrating the skin. And that infiltration is what causes the visible skin lesions. They often start as flat patches, then maybe progress to thicker, raised plaques, and sometimes eventually form tumors.
Got it. Skin cancer from a specific immune cell. And you mentioned classification.
Yeah, it's classed as a primary cutaneous lymphoma within that CTCL group. And there are variants, too, important ones like folliculotropic MF. That's where the cells gather around hair follicles, and pegetoid reticulosis, which is more localized, often like on the arms or legs. And like other cancers, it uses the T&M staging system. D for tumor, how much skin's involved. N for node involvement. M for metastasis, spread to other organs. Stages run from very early IA up to advanced IVB.
Okay, specific skin lymphoma, different forms, standard staging. So what causes it? Do we know?
Well, that's the thing. The exact cause is actually unknown. But the current thinking links it to acquired genetic mutations in the T-cells themselves. Basically, these mutations make the T-cells go rogue, multiply when they shouldn't, and turn cancerous.
So rogue T-cells. But are there specific things that make someone more likely to get these mutations? Any clear risk factors?
This is really interesting, especially for revision. The information we have points to no well-defined risk factors.
Really? No clear risks? That seems, well, unusual for a lymphoma type. You often hear about exposures or genetics.
It does seem unusual, yeah.
Oh.
And it really highlights how much we're still learning about it. So while the cause isn't pinned down, we do see patterns. It mainly affects adults, usually diagnosed over 50. And there's a slight tendency for it to affect men more often than women. But specific triggers, environmental things, lifestyle, strong inherited links beyond those cell mutations, the sources don't point to any established ones.
Okay, so a bit of a mystery origin, no smoking gun risk factors. The notes also mention Sézary Syndrome. How does that fit in? Ah, yes, Sézary. That's a key association. It's considered a related but distinct and usually more aggressive form of CTCL. People often discuss them together because they both involve malignant T-cells. While mycosis fungoides is often described as indolent, meaning slow-growing, Sézary syndrome is generally more aggressive. It makes up maybe 5% of CTCL cases and presents quite differently. You see this widespread skin redness called erythroderma, like the whole skin is red and inflamed. And critically, you find these abnormal-looking cancerous T-cells, they call them atypical T lymphocytes, actually circulating in the blood, often with features of leukemia, meaning lots of them in the bloodstream.
So Sézary is like the systemic version, more aggressive, involves the blood from the get-go. Kinda, yeah. Whereas mycosis fungoides typically starts in the skin and can stay confined there for a long time. It's useful to contrast MF and Sézary with other, even more aggressive CTCLs mentioned, like peripheral T-cell lymphoma or the one linked to HTLV1. Those usually run a faster course, often involving nodes and organs much earlier. So, for revision, think. MF is the most common, slowest CTCL. Sézary is the blood-involved, aggressive one, and the others are often systemic and rapid. That's a decent summary.
That makes sense. Okay, thinking about the mechanism, what's actually happening in the skin, the pathophysiology.
Right. It starts with what's called a clonal expansion of malignant CD4 plus T-helper cells. Think of CD4 plus T-helper cells as kind of the commanders in your immune system army. In F, one of these commanders goes rogue, picks up a genetic fault, and just starts making copies of itself uncontrollably. That's the clonal expansion.
Millions of copies of just one faulty cell.
Exactly. And unlike healthy immune cells that patrol everywhere, these malignant ones seem to have a weird attraction, a homing instinct For the skin, the why isn't totally clear. So they infiltrate the skin layers, build up there, and it's their presence and activity that creates the patches, the plaques, and maybe later the tumors. And then in some cases, as the disease progresses, these cells can spread out maybe to nearby lymph nodes first, and then in more advanced stages, travel via blood or lymphatics to other internal organs.
Okay. Now, given it starts looking like common things like eczema or psoriasis, the initial diagnosis must be incredibly tough. What are the absolute key differential diagnoses someone revising for MSRA has to keep in mind?
Oh, this is super high yield.
Yeah.
Because the list is long. And yeah, it's a great mimicker early on. You've got to cast a really wide net. The notes break it down. First, you've got other cutaneous lymphomas, other skin lymphomas. Things like lymphomatoid papulosis that often looks like reddish-brown bumps. They can come and go but tend to recur. Sézary Syndrome, like we just discussed, with the redness and blood involvement. And primary cutaneous anaplastic large cell lymphoma that usually presents as faster-growing nodules or tumors.
Okay, so rule out other skin lymphomas first. What about the non-cancerous stuff it looks like?
Absolutely. These are probably the most common initial mix-ups. Common inflammatory skin conditions, psoriasis, obviously, the well-defined silvery scales on red plaques, often elbows, knees, scalp. And eczema, itchy, inflamed, dry, scaly patches, pretty much anywhere. The notes actually say all kinds of dermatitis and eczema, really hammering home how varied eczema looks and how easy the confusion is. Beyond those big two, you need to think about adverse drug reactions causing rashes. Psoriasis, that's a group of conditions with scaly patches that sometimes can actually progress to MF, making it tricky. Lichen planus, itchy, purplish, plecolenal bumps, often wrists, ankles, maybe mouth. Morphia, hardened skin patches. Paniculitis, inflammation of the fat layer. Folliculosis, inflamed hair follicles.
Wow, okay. That's a lot of possibilities already.
It is, and it keeps going. Pityriasis lichenoides, chronica, and the acute form, PLVA, they cause small spots, sometimes scaly, sometimes blistery. Pigmented purpuric dermatoses, those look like reddish-brown patches from leaky, tiny blood vessels. Even vitiligo, loss of pigment, is on the list. The sheer length of this list tells you something really important. For any persistent, weird-looking rash that just isn't getting better with standard treatments for eczema or psoriasis, Mycosis fungoides has to be on your differential diagnosis list. It should prompt that thought. Could this be something else?
That's a massive takeaway for exams and practice. So how common is it then? What's the epidemiology?
Overall, rare. Makes up maybe 3% of all lymphomas diagnosed. In the UK, the incidence is estimated at around 0.5 to 1 case per 100,000 people each year.
So really not something you'll see every day in clinic.
Definitely not. Which, again, adds to why it can be missed early on. It affects people of all ethnic backgrounds. Now, looking within the whole cutaneous T-cell lymphoma group, the overall CTCL incidence is similar, about 0.5 per 100,000. Primarily adults, median age around 55-60. But here's the key point. Mycosis fungoides is the most common subtype of CTCL. It accounts for something like 44% to 62% of all CTCL cases. So while CTCL itself is rare, if you do encounter a CTCL, the odds are pretty high that it's Mycosis fungoides.
Right, that puts it in perspective. Okay, shifting to the patient's experience clinical features, what does it typically look and feel like?
Well, the classic start, as we've touched on, is those reddish, scaly patches or plaques.
Yeah.
Initially, yeah, they can be subtle, look a lot like eczema or psoriasis. That's the diagnostic headache.
Do they tend to show up in specific places?
Often, yes. These early lesions frequently appear in areas usually covered by clothing, not exposed to sun like the buttocks, hips, trunk. That pattern can sometimes be a subtle clue, maybe distinguishing it from sun-related issues. Then, over time, and this could be years, these patches might evolve. They can become thicker, more raised, forming distinct plaques, and then in later stages, they might progress further into actual raised lumps or tumors on the skin.
And symptoms. What does the patient feel?
Itching, often severe itching. It's incredibly common and can be one of the most distressing symptoms for people living with it. Then in more advanced stages, if it spreads beyond the skin, you might find enlarged lymph nodes or perhaps signs relating to internal organ involvement, but that's less common early on. Oh, and the notes mention the skin lesions can have varying colors, which sometimes might help tell them apart from the more uniform look of other conditions.
So varied look, often itchy, evolves slowly. Given all that and the huge differential list, how do you actually confirm the diagnosis? What investigations are key?
Clinical evaluation is always step one, of course. Looking closely at the lesions, taking a detailed history, asking how they've changed over time. But the absolute cornerstone, the definitive test for diagnosis, is a skin biopsy.
Right. Why is the biopsy so critical?
Because under the microscope, the pathologist can actually see the specific features of those abnormal T cells invading the skin. That's characteristic of MF. They look for patterns, like something called epidermotropism. That's the malignant T cells moving up into the epidermis, the top skin layer. Sometimes they form little clusters called Potrier microabscesses. These are microscopic hallmarks you just don't see in eczema or psoriasis. Then, to really nail down the diagnosis and rule out mimics, they do extra tests on that biopsy sample. Things like immunohistochemistry, using special stains to identify markers on the cells, flow cytometry, analyzing thousands of cells quickly, and molecular studies looking for specific genetic changes like T-cell receptor gene rearrangements, which basically prove the cells are clonal, all copies of that original faulty one.
What about blood tests or scans?
Blood tests like liver function tests, LFTs, and uric acid are usually done. More to get a baseline, check overall health, maybe monitor for organ involvement later on, especially if Sézary Syndrome is suspected. Imaging like a chest x-ray, maybe CT scans of the chest, abdomen, pelvis that's usually kept for assessing more advanced disease. If you suspect it spread to lymph nodes or internal organs based on the exam or symptoms, you might do other biopsies like the lymph node or bone marrow, but again, only if there's a strong clinical reason to suspect spread beyond the skin like really big lymph nodes or systemic symptoms. But it's crucial to remember early MF can be really tricky, even for pathologists. The biopsy might not be completely clear-cut initially. The notes really emphasize that in early cases, diagnosis often needs integrating everything. The clinical picture, what the biopsy shows, even if subtle, and those molecular findings. It's like putting puzzle pieces together, often using algorithms to guide the process when things aren't black and white.
Okay, so clinical suspicion, the vital skin biopsy, maybe other tests if you're worried about spread. Once it is diagnosed, how is mycosis fungoides managed? Thinking particularly about UK approaches mentioned.
Right, management. It's heavily dependent on the stage of the disease.
Sure.
And a core principle stated clearly in the notes is that mycosis fungoides and Sézary syndrome too are rarely curable. So the treatment goals are mainly about controlling the disease, managing the symptoms like itching, trying to prevent it progressing, and maintaining quality of life, all while minimizing treatment side effects.
So it's really about managing it as a chronic condition then.
Exactly that. For the earlier stages, typically stage IA, IB, sometimes IIA where it's limited to patches and plaques without major node involvement, the focus is on skin-directed therapies. That includes basic symptomatic stuff, emollients for dryness, anti-itch creams or tablets, then the specific skin treatments. Topical corticosteroids are very common steroid creams or ointments. Topical retinoids like tazarotene or bexarotene gel. Sometimes topical chemotherapy agents like nitrogen mustard or carmustine applied to the skin. And phototherapy using specific UV light. That could be UVB light or PUVA, which combines a drug called Sorlin that sensitizes the skin to light with UVA light. These all target the bad T cells just in the skin.
Okay, so local treatments for local disease. What happens if it's more widespread or the skin treatments start working?
Right, that's when you have to consider systemic treatment therapies that work throughout the whole body. These come into play for relapse disease or refractory disease, meaning it didn't respond well, or more advanced stages. So, stage IIB and upwards, where you have skin tumors or very widespread plaques, or definite lymph node or organ involvement. The systemic options listed include things like interferon, that's an immunotherapy, various chemotherapy agents, though often used one at a time rather than harsh combinations, oral retinoids like bexarotene capsules, and other targeted agents are becoming available too. For really advanced or difficult cases, there are more intensive options. Immunomodulatory therapies like extracorporeal photopheresis or ECP, that's where blood is taken out, treated with a drug and UV light to target the T cells, and then put back in. And in very specific, rare situations, maybe younger, fitter patients with aggressive disease stem cell transplantation might be considered, but that's a major procedure with significant risks.
And the notes mention something specific about avoiding combination chemo.
Yes, and that's a really key point for revision. Combination chemotherapy, the sort of multi-drug regimens used for many other lymphomas, is generally avoided in mycosis fungoides. Why? Well, apparently the response rates aren't that great in MF anyway, and crucially, these strong chemo regimens significantly increase the risk of serious infections. Patients might already be a bit immunocompromised from the MF itself or other treatments. So while systemic drugs are used, single agents or non-chemo options like interferon or ECP are often preferred before jumping to really intensive chemo.
Okay, so it's a stepwise approach. Start local and simple for early disease. Escalate carefully to systemic treatments for advanced or resistant cases, always balancing benefit against risk, especially infection risk. What about the long view? the prognosis.
Yeah, prognosis. It varies hugely depending on the stage when it's diagnosed. For early stages like IA and IB, the outlook is actually quite good. The notes mention around an 80% 5-year survival rate.
That's a massive difference based on catching it early versus late.
Absolutely. It really highlights why trying to nail that tricky early diagnosis is so important. But even in early stages, it's still seen as a chronic disease. It needs long-term management, long-term follow-up, because it often recurs. It can come back even after treatment worked initially. Unfortunately, for the later stages, IIB, 3, 4, the prognosis gets significantly worse, and complications become a major factor driving increased mortality.
Right. What sort of complications might someone with MF face, especially in those later stages?
Several types are highlighted. Skin infections are a big one. The skin barrier is disrupted. The immune system might be weakened by the disease or treatment. So bacterial, fungal, viral infections are more common. There's also an increased risk of getting secondary malignancies, completely separate cancers. That can include other skin cancers like melanoma or squamous cell carcinoma, but also internal cancers. The notes mention colon cancer, Hodgkin's lymphoma, and other types of non-Hodgkin's lymphoma. Then, for patients with advanced disease where the lymphoma cells spread, you can get systemic complications. Things like lymphadenopathy, enlarged lymph nodes, hepatosplenomegaly, enlarged liver and spleen, and potentially dysfunction of other organs if they get infiltrated. And of course, the risks associated with the treatments themselves, particularly immunosuppression, increasing infection risk.
So regular follow-up seems absolutely critical then, not just for the MF, but for catching these other potential problems.
Exactly. The notes really stress that regular, lifelong follow-up is essential for anyone with mycosis fungoides, specifically looking for any signs the disease is progressing or spotting these potential complications early when hopefully they're more treatable.
Okay, so we've done a pretty thorough sweep through mycosis fungoides based on your revision material. We've covered what it is that rare CTCL, the great mimicker, touched on the unknown cause, linked to T-cell mutations but no clear risk factors, walked through the pathophysiology, rogue T-cells loving the skin, navigated that huge, tricky list of differentials, highlighted its epidemiology rare overall, but the most common CTCL, described the evolving clinical picture, outlined the diagnostic steps, pivoting on that skin biopsy, and finally discussed the stage-based management control, not cure, and the potential complications and prognosis. That feels like a really solid, high-yield run-through.
It really does. I think consolidating those details, especially the differentials, the absolute need for biopsy, the stage-based treatment ladder, and that list of complications, that's absolutely key for understanding it properly and, yeah, for exam prep.
Just thinking about exams and real life. Given how often MF starts looking like plain old eczema or psoriasis, what should really make a junior doctor or GP stop and think, hang on, could this be something more serious? Is it just not responding to treatment, or are there more subtle early clues they should be actively looking for?
That's the million-dollar question, isn't it? It's often a mix. Persistence despite trying appropriate treatments for the common stuff, that's a massive red flag, definitely. But also, actively looking for those subtle clues we mentioned. Are the lesions in slightly unusual places for typical eczema or psoriasis, like the buttocks or trunk? Is there variation in color within the lesions? Is the itching really severe? It maybe seems out of proportion to how the rash looks. Those sorts of things, even if subtle, should trigger that thought process. Okay, this isn't quite fitting the pattern. Maybe I need a dermatology referral. Maybe we need to think about a biopsy sooner rather than later.
That's a brilliant practical point to end on. Remember, for more free MSRA revision resources, you can visit freemsra.com, and for the full premium revision toolkit, head over to pastmsra.com.